What I'm about to show you is going to make you question everything you've ever been told about the female body. And when I reveal the one truth almost nobody explains clearly, you're going to understand why so many women and so many husbands spend years feeling confused, embarrassed, or quietly convinced that something must be wrong. Because there is a female erection. Yes, an actual physical process. Not a myth, not a joke, not some vague romantic phrase. A real biological event driven by blood flow, nerves, hormones, and the brain. And once you understand how it works, a whole lot of confusion suddenly starts making sense. I'm Dr. Michael Joel, and today I need to explain something medicine should have explained to people decades ago. Before we begin, please subscribe to this channel for clear, honest health guidance that protects your confidence, comfort, and peace. Here's why this matters so much. Right now, somewhere in America, a woman in her 60s or 70s is wondering why intimacy feels different than it used to. Somewhere else, a man who loves his wife is assuming her body just isn't responding anymore. And both of them may be misreading what's actually happening inside the body. Let me tell you about Helen first, because her story reveals the confusion better than any textbook ever could. Helen was 72, a retired school librarian in Sarasota, Florida. Smart, thoughtful, careful, the kind of woman who reads every medication insert and asks excellent questions at every appointment. She came to see me after months of worry. She said, "Doctor, nobody ever taught me this, but I need to know if I'm normal." She told me she still felt affection, still wanted closeness, still loved her husband deeply. But the physical response felt different from what she remembered. Slower, subtler, less obvious. And because no one had explained female erection properly, she assumed her body was failing. Now here is the first thing you need to understand, and it changes everything. When people hear the word erection, they usually picture one thing and one thing only: a penis becoming firm and visibly enlarged. That narrow definition has caused decades of misunderstanding. In women, the erectile response is real, but it is built differently, looks different, and is mostly hidden from view. The female erection is not the vagina becoming hard. It is the clitoral tissue and nearby erectile structures filling with blood, swelling, becoming more sensitive, and helping prepare the body for sexual pleasure and comfortable intimacy. That is the truth, and it is long overdue. And here's where almost everyone gets misled. Most people think the clitoris is just that tiny visible part at the top of the vulva, the little external nub people can see or feel. But that is only the part you can see from the outside. It is not the whole organ, not even close. The visible tip is only the front edge of a much larger structure that extends internally. So when a woman says, "I don't see much happening," that does not mean nothing is happening. It may mean the most important changes are taking place beneath the surface, inside tissues no mirror is ever going to show you. That is the part nobody explains. So let's slow this down and make it simple. The external part is called the glans clitoris. That's the sensitive part most people know about. It sits under or near the clitoral hood. But inside the body, the clitoris extends backward into a larger structure with a body, two crura, which are like internal legs, and vestibular bulbs that sit alongside the vaginal opening. Think of it less like a button and more like a wishbone-shaped network of sensitive erectile tissue. When arousal begins, blood starts moving into these tissues. They swell. They become more responsive. They support pleasure. They help create the physical conditions for intimacy. And yes, that is a female erection. Now let me show you the mechanism, because once you understand the mechanism, the mystery disappears. Sexual arousal starts with the brain, the nerves, or physical stimulation, and often all three at the same time. The brain recognizes something as sexual, intimate, meaningful, exciting, or emotionally safe. Nerve signals travel. Blood vessels in the genital area widen. Blood flow increases. As that happens, the clitoral erectile tissue fills and expands. The surrounding tissues become fuller. The vaginal walls also receive more blood flow. This is called engorgement. That word matters, because engorgement is the heart of the process. It is not imaginary. It is not all in her head. It is a measurable physical event. But here's the part that confuses many couples. Lubrication and erection are related, but they are not the same thing. A woman can have clitoral swelling and increased sensitivity without dramatic lubrication. And she can also have some lubrication without feeling fully aroused emotionally. Those are not contradictions. They are simply proof that the female sexual response is more complex than people were taught. Blood flow contributes to swelling, and pressure from that swelling helps trigger fluid secretion in the vagina. But hormones, age, medications, hydration, stress, and tissue health all affect how noticeable that lubrication is. So if someone says, "I'm wet but not mentally there," or "I care but I'm dry," both experiences can be real. That leads us to something even more important, especially for older adults. Desire and arousal are not always synchronized. In plain English, wanting intimacy and having the body respond do not always happen in the same order. Sometimes desire comes first. Sometimes physical arousal starts first and emotional desire follows. Sometimes a woman feels love, trust, and willingness, but her body takes longer to catch up. Sometimes the body shows reflexive signs of arousal even when the mind is distracted. That does not mean anyone is broken. It means the system is more layered than most people realize. And if you judge the entire experience by one sign alone, you will misunderstand what the body is doing. Let me put this into the framework doctors use because it may help you see the process clearly. The sexual response cycle is often described in phases: desire, arousal, orgasm, and resolution. Now, real life is not always neat enough to follow those phases in perfect order, but the framework helps. During arousal, blood flow rises, the clitoris swells, the vaginal walls become fuller, lubrication may increase, breathing and heart rate can climb, and sensitivity intensifies. During orgasm, muscle contractions and a release of tension may occur. During resolution, the body gradually returns to baseline. That's true whether someone is 35 or 75. The physiology still exists, even when the experience changes with age. Now, let me tell you something that surprises many women. The more aroused the clitoris becomes, the more sensitive it can feel, and sometimes that sensitivity becomes almost too much. Some women assume this means something is wrong. It doesn't. In fact, it often means the tissue is highly engorged and the nerve endings are responding intensely. That is one reason direct touch can feel pleasurable at one moment and overwhelming the next. It's not inconsistency. It's physiology. As blood flow increases and the glands becomes more sensitive, what feels comfortable can change minute to minute. So if a woman says, "That felt good a second ago, but now it's too much," that's not strange. That is the body speaking. And this is where Helen's story started to turn. She had spent years assuming that if she did not have the same obvious, immediate response she remembered from younger adulthood, then the machinery itself must be gone. But when we talked through the anatomy, the timing, the effect of menopause, and the hidden internal structure, she looked at me and said, "So you're telling me the response is still there? I just haven't understood the signs." Exactly. That was the moment everything changed for her. Not because I gave her some magic treatment that day, but because fear was replaced with understanding. And when fear leaves the room, the body often responds with less tension and more trust. Now we need to talk about menopause because for women over 60, this is often the missing chapter. After menopause, estrogen levels decline. That change affects the genital tissues in very practical ways. Blood flow to the pelvis may be reduced. The vaginal lining may become thinner, less stretchy, and more easily irritated. Natural lubrication can decrease. Arousal can take longer. Orgasms may feel different. None of that means pleasure is over. None of that means the female erection disappears. It means the same response may need more time, more comfort, more communication, and sometimes medical support. But because nobody says this out loud, many women interpret a slower response as personal failure instead of normal physiology. Let me tell you about Carol in Columbus, Ohio. Carol was 68, recently retired, deeply in love with her husband, and absolutely certain her body had shut down. That was her phrase, shut down. She said the desire was there sometimes, but her body did not respond the way it had in her 40s. She felt dry more often. She needed more time. Touch that used to feel natural sometimes felt irritating. She thought she was doing something wrong. What was actually happening was a classic menopause-related shift in tissue response. The blood flow was still possible. The erectile tissue was still there. The nerve network was still there. But the hormonal environment had changed, and the body needed a different approach. That is why older women are so often given the wrong message. The public message is crude and simplistic. If you're aroused, your body should instantly perform in one obvious way. But the medical truth is far more compassionate. Arousal in later life can still be strong, meaningful, and deeply pleasurable, but it may be quieter at first. It may need more time. It may depend more on relaxation and less on rushing. It may require addressing vaginal dryness or pain directly instead of pretending those issues don't exist. In other words, the female erection does not vanish. The conditions surrounding it change. And if you don't understand that, you can mistake a need for support as a loss of function. Here's another truth almost no one explains. Being slower to respond does not mean being less sexual. I want every woman listening to hear that clearly. If it takes longer for the clitoral tissue to swell, if the vaginal tissue needs more comfort, if emotional safety matters more than it used to, that is not evidence of defect. It is evidence of a body that deserves respect, not pressure. Too many couples panic the moment things aren't immediate. And panic is poison to arousal. The moment someone starts thinking, why isn't this happening faster? The nervous system shifts toward anxiety. Blood flow pulls back. Muscles tighten. The body becomes guarded. So sometimes what people call dysfunction is actually fear interrupting physiology. Let me show you another piece of the puzzle, because aging is not the only factor. Medications and chronic conditions matter too. High blood pressure, diabetes, heart disease, depression, anxiety, and some of the medications used to treat these conditions can affect sexual response. Why? Because blood flow matters. Nerve health matters. Hormones matter. Brain chemistry matters. Arousal is not one switch. It is a coordinated event involving circulation, sensation, tissue response, mood, and context. If one part of that chain is disrupted, the entire experience may feel muted or delayed. That does not always mean something is seriously wrong, but it does mean the answer may be medical, not moral. And that distinction matters enormously. Let me tell you about Nancy from Phoenix, Arizona. Nancy was 70, active, sharp, and frustrated. After a heart procedure and several medication changes, she noticed intimacy felt different. Her husband assumed she had simply lost interest. Nancy assumed it was all in her head. Neither explanation was right. Her medication list included drugs that could influence blood pressure, sensation, and energy. She was also sleeping poorly, which made everything worse. What she needed was not shame. What she needed was a careful conversation about circulation, medication side effects, sleep, stress, and menopausal tissue changes. Once those pieces were addressed, the problem became understandable. And once it became understandable, it stopped feeling like a personal mystery. Now let's talk about the brain, because the brain is not a side character in female erection. The brain is central. Safety, trust, attraction, attention, privacy, stress, grief, resentment, body image, and fatigue all influence arousal. A woman can have healthy anatomy and still struggle with response if her nervous system is preoccupied, tense, or emotionally disconnected. That does not make the experience imaginary. It makes it human. Sexual response in women is strongly shaped by context. If the setting feels rushed, exposed, emotionally cold, or pressured, the body may resist even when love is present. So when couples ask, why isn't the body responding? Sometimes the answer is not hidden in the pelvis. It is hidden in the atmosphere around the moment. Let me give you a real-world example. Barbara, 66, from Dallas, Texas, told me she loved her husband, but every intimate moment had started to feel like a test. Would her body respond? Would she feel pain? Would she disappoint him? That pressure was enough to make her entire system tighten before intimacy even began. So even though the anatomy was normal, the experience became harder and harder. This is the cruel cycle many older couples fall into. One disappointing experience creates vigilance. Vigilance creates tension. Tension reduces arousal. Reduced arousal creates another disappointing experience. And around it goes. Understanding female erection helps break that cycle because it shifts the question from what is wrong with me to what conditions does my body need? And that is a much kinder question. Here is another important truth. The body can show physical arousal without strong conscious desire, and conscious desire can exist before the body is fully ready. People often think those two should always match perfectly, but they don't. The genital tissues can respond reflexively to stimulation or erotic cues before a woman feels fully mentally engaged. Likewise, a woman may deeply want closeness and still need more time before swelling, lubrication, and comfort develop. This is especially important for older adults who have spent decades believing the body should work on command. It doesn't. It works through a conversation between brain, nerves, blood flow, hormones, and context. And like any real conversation, sometimes one side speaks before the other catches up. Now let me address the question many viewers are already thinking. If a female erection is real, why don't we talk about it the way we talk about male erection? The answer is simple and tragic. Visibility. Male arousal is more outwardly obvious. Female arousal is more internal, more variable, and more dependent on subtle tissue changes people were never taught to recognize. That invisibility has allowed ignorance to survive for generations. Entire marriages have been shaped by misunderstandings that could have been prevented with a decent anatomy lesson. So if you grew up never hearing this phrase, if you were married for 40 years and nobody ever explained it, please hear me clearly. The silence was cultural. The silence was educational. The silence was not proof the process wasn't real. It was proof nobody taught it. And this is the single most important visual to hold in your mind. The visible glans is only the tip. The internal clitoral body, the crura, and the vestibular bulbs are where much of the erectile response lives. When those tissues fill with blood, they create fullness, sensitivity, and pressure around the vaginal opening and walls. This is one reason arousal can make intimacy feel entirely different even when there is no dramatic visible change on the outside. It is happening in 3 dimensions, inside tissues you cannot casually inspect. That is why a woman may say, "I can feel the difference," even if a partner says, "I can't really see anything." Believe the feeling. The feeling is real. The anatomy supports it. Now here comes a myth that causes enormous confusion. Many people use the word vagina when they are actually talking about the entire genital area. But the vagina is the internal canal. The clitoris is a separate organ, and it is central to the erectile response. So when someone asks whether the vagina gets an erection, the precise answer is no, not in the way people mean it. The vagina becomes more engorged because blood flow to the area increases and the vaginal walls can swell and darken in color, but the primary erectile organ is the clitoris and its associated structures. That distinction matters because it explains why pleasure, sensitivity, and arousal can be strong even when people are looking in the wrong place. And many people have been looking in the wrong place. Now let me be careful here because comparison can help or harm depending on how it's used. A female erection is similar to a male erection in one crucial way. Erectile tissue fills with blood and changes the physical state of the genital area. But it is not identical. The anatomy is different. The visual signs are different. The timing may be different. The relationship between desire, lubrication, swelling, and orgasm may be different. If you expect a woman's arousal to look like a smaller version of male arousal, you will misunderstand it completely. This is not the female body doing a lesser version of the male body. It is the female body doing its own version of arousal. And once you stop forcing the comparison, the whole process becomes easier to understand. Let me tell you about Susan from Des Moines, Iowa, because her story captures this perfectly. Susan was 64 and felt embarrassed that she now relied on lubricant more than she had in earlier years. She saw that as evidence her body had stopped working, but lubricant is not evidence of failure. It is a support tool. Menopause can reduce natural moisture even when desire and erectile response are present. So, a woman may feel mentally interested, may have internal swelling, may have clitoral sensitivity, and still benefit greatly from added lubrication. Those things can all exist together. The mistake is assuming one sign cancels the others. It doesn't. The body is more nuanced than that, and older adults deserve explanations built on nuance, not shame. That brings me to pain, because pain changes everything. If intimacy hurts, the body learns to brace. Once bracing begins, arousal is harder, swelling is reduced, lubrication may lag, and the cycle becomes self-reinforcing. Pain is not something to tough out in silence. Pain is information. It may point to menopause-related tissue changes, dryness, pelvic floor tension, medication effects, infection, skin conditions, or other treatable issues. Too many women in America have spent years assuming pain is simply the price of aging. It is not. Pain deserves medical attention, especially when it is new, persistent, or getting worse. Because when pain enters the picture, the question is no longer just, how does a female erection work? It becomes, what is interfering with it? Now, I want to tell you something reassuring that many couples need to hear. The response does not have to look dramatic to be meaningful. Some women experience very obvious swelling and heightened sensitivity. Others experience subtler changes, fullness, warmth, pressure, increased awareness, or a shift in comfort and receptivity. Bodies vary, medications vary, hormone levels vary. Life history varies. There is not one universal appearance or timeline. So if you are searching for one cinematic sign that proves arousal is happening, you may miss the actual reality. The actual reality is often quieter, more internal, and more personal than people expect. And the older we get, the more important it becomes to pay attention to lived experience rather than youthful stereotypes. But there is also a line where reassurance should give way to evaluation. If arousal feels impossible, if lubrication has changed dramatically, if there is persistent dryness, numbness, pain, bleeding, burning, or distress that is worth discussing with a clinician. If medications changed and intimacy changed right along with them, bring that up. If menopause symptoms are affecting comfort, bring that up. If a woman still has desire but the body never seems to follow, bring that up. This is not trivial. This is quality of life, relationship health, self-esteem, and physical well-being. Doctors should be talking about this more. Patients should not have to drag the subject into the room alone. But until that culture changes, I want you to know the conversation is valid. And when you do have that conversation, a good clinician will think broadly. They may consider hormone changes, tissue health, pelvic blood flow, medication effects, diabetes, heart disease, sleep quality, mood, anxiety, depression, relationship strain, and pain disorders. In other words, they should not reduce the issue to one simplistic explanation. They should not tell a woman over 60, well, that's just aging. and leave it there. Aging changes physiology, yes, but changed is not the same as hopeless. Changed is not the same as invisible. Changed is not the same as untreatable. If something matters to your well-being, it matters medically. And one of the worst habits in medicine has been acting as though older women's sexual health is optional. It isn't. Now let me give you the simplest explanation I can, the one I wish every American adult had heard in high school. A female erection is the process in which sexual stimulation, emotional connection, or erotic signaling increases blood flow to the clitoris and nearby erectile tissues, causing swelling, increased sensitivity, and physical readiness for intimacy. That process may also contribute to fullness in surrounding tissues and increased vaginal secretions. It may be obvious or subtle. It may happen quickly or slowly. It may be influenced by age, hormones, medications, health conditions, stress, and the quality of the relationship. But it is real. It is normal. It is biological. And no one should have to reach their 60s before hearing that explained clearly. Here's the next truth I want burned into your memory. If a woman does not lubricate easily, that does not prove she is not aroused. If she needs more time, that does not prove she is not interested. If she's interested but becomes uncomfortable, that does not prove the relationship is broken. And if she says things feel different after menopause, believe her. The older female body is not a failed younger body. It is its own body operating under new conditions with new needs, new strengths, and sometimes new challenges. The more respectfully those conditions are understood, the more successful intimacy usually becomes. Pressure shuts this system down. Understanding helps it open. And that is as true in biology as it is in relationships. Let me return to Helen because I want you to see what changed. Once she understood that the female erectile response was still present, that much of it was internal, that menopause had changed the environment but not erased the anatomy, she stopped narrating every intimate moment as a test she might fail. She became more patient with her body. Her husband became more informed and less anxious. They stopped treating slowness as catastrophe. They started treating it as information. That shift matters more than most people realize, because the body responds differently when it is not being interrogated. The nervous system relaxes, blood flow improves, muscles soften, the experience becomes possible again. And sometimes education is not just information, sometimes it is relief.